Today we'll learn about posterior uveitis. Although this is supposedly not a topic to be taught in detail to undergraduates, but a slight idea is important for understanding the uveitis which affects the eye. Now let us see what is posterior uveitis by definition. So as per Sun classification, that is standardization of uveitis nomenclature, the uvea has been divided into three parts: the anterior, which consists of the iris and the ciliary body; the intermediate, which consists of the pars plana; and the posterior uvea, which is the choroid. Now, if all three regions are affected, this is known as panuveitis. And if just the posterior uvea, that is the choroid, is involved, along with retina and vitreous, it is known as posterior choroiditis. Now there is a classification according to the clinical presentation of uveitis, and let us see what does it mean. Now focal choroiditis is when you have just a single foci of choroidal inflammation, although this may involve some amount of retinal tissue, but it is localized primarily in the choroid. As we can understand that when the choroid gets inflamed, it becomes opaque, the overlying retina becomes slightly hazy and opaque, and there is presence of cells in the vitreous, so view may become slightly hazy. More so, collection of exudates in the retina and choroid layers can cause opacity in the view of the choroid. So this will usually appear as a creamy yellow to white spot or an area in the retina or the fundus view, which we can see as an area of inflamed choroid. Now this focal choroiditis, I would like you to see this. If we can look at this optical coherence tomography image, we can see that this is the choroid which has thickened. It is edematous, it has deformed the overlying layers of retina, but we can also appreciate that the overlying retina has no edema. So this indicates that this inflammation is primarily in the choroid layer. It has not infiltrated into the retina. Then we can have multifocal choroiditis. So this is a clinical entity where you can see multiple foci of choroiditis which are separate from each other, and they are distant from each other, affecting separate areas of choroid. This is termed as multifocal choroiditis. Then you can have diffuse choroiditis. Here we can see the difference, that there are areas of choroiditis which are affecting a larger area of choroid, but they are touching each other. So there is a contagious spread of inflammation because of the primary disease which is affecting the choroid. Then we can have chorioretinitis. Chorioretinitis is basically something like choroiditis where you have inflammation of overlying retina also. So in this OCT we can see that this is the area where you have the inflammation, that is choroiditis, and then in the OCT where you can see the section of the tissue, we can appreciate that this portion of the retina is edematous when it is compared to the other part, and this is the area of inflammation. And after treatment, when the inflammation has subsided, we can appreciate that this opacity is vanished and we have a scar tissue where we can also appreciate that there is a loss of retinal cells and retinal layer. Then we can have retinochoroiditis, where it is inflammation primarily of retina, and then when the scar heals, we can see there is a large defect in all the layers of the retina and choroid, and we can appreciate the pigment dispersion and presence of visibility of sclera which is underlying all these layers. So there is complete atrophy of the overlying retina and choroid. Then there is involvement of optic nerve head along with the retina and choroid. That means this is known as neuroretinitis. So when there is optic nerve involvement, it is neuroretinitis. Now looking at the causes of posterior uveitis, we have to understand that choroid is a very vascular structure, and that is why it has free access to the circulating pathogens in the blood, and because it is also a site of immune reaction caused by the immunity system and the inflammatory cells in the body. So that is why it is prone to have infections as well as inflammations due to autoimmune diseases. So one of the diseases, so let us look at the infective causes, and we can see the toxoplasmosis is one parasite which usually infects the cats and other animals, and this cycle usually is contained within this ecosystem of cat which eats these animals. And when these oocysts which are excreted in the feces of the cat, they are ingested by humans, or the tissue cysts which are present in the meat of these animals, they are eaten uncooked or raw by the human beings, then this can cause toxoplasmosis, which is a syndrome itself, and it can affect nearly all the organs of the body, including the eye. So this is the parasite which is seen in a stained slide, and this is a picture of a fundus of a person which is affected by toxoplasmosis in the intrauterine life. So it has affinity for the macular area. So we can see in both the eyes the macular area has been destroyed, and this is congenital toxoplasmosis. The visual prognosis is very poor, and the child is born with this defect. It is a punched out defect in both the eyes, may appear like a coloboma of the tissue also, but it is congenital toxoplasmosis. In acquired condition, the toxoplasmosis can affect the choroid and retina, and it basically causes chorioretinitis, where there is involvement of retina as well as choroid, and this is one foci which is seen as an inflamed portion of the choroid along with retinal inflammation. Then we have another disease, which is toxocariasis, and this is a worm which is found in puppies and dogs, and the life cycle varies between the prey and the predator, that is the dog and other animals. And when this larva reaches to a human being, it can cause systemic diseases because of this worm which is lodged in the human body in various organs, and it can also cause, so this is the worm which is supposed to cause toxocariasis worm, and which is supposed to cause diseases in the human being, which is not the definitive host. But once a person ingests the larvae and eggs, and the larva hatches, it can migrate in the body various organs. And this is one of the patient in which you can see a wide angle photograph of the fundus. This is the optic disc, and there's a peripheral granuloma which is reached a stage of scarring, and initial inflammation is vanished, and this scar causes shortening of this retinal tissue, in which we can see the macula or the fovea is involved, and there's a traction detachment which is caused this area of the retina to detach, and this is a peripheral granuloma which has caused this shrinking and inflammation. After inflammation, the scar forms which shrinks and causes shortening of the retina in this particular meridian. You can see the macula is detached. Tuberculosis, as we all know, can affect nearly all the organs of the body, so same with the choroid. This is a patient with multifocal choroiditis because of tuberculosis, we can appreciate that there are few areas which are having active choroiditis. This is the area which is appearing creamy yellow plaque, and rest of the areas which are appearing gray and pigmented, these are all areas of old activity where the disease has occurred and it has now healed. So there's a scarring here. So this patient is an ongoing active disease in these areas plus old disease which was there and it has healed, resulting to a scar. If the fovea or the macula is involved, the vision is very poor in these patients, and usually this disease after scarring cannot recover. Only thing treatment we can do is to prevent the spread and uh, involvement of newer areas. Now I'm not going to discuss about syphilis and Bartonella because these are rare diseases now. Coming to other infective causes which are more common are herpes simplex, varicella zoster and cytomegalovirus. And this is a patient in whom we have the uh, retinitis caused by herpes simplex virus, and these viruses basically cause a huge amount of damage to the retina, and we can see the retina is grossly inflamed. These diseases are common in immunodeficient individuals, especially HIV positive patients who are having low immunity, and that is why these viruses have an opportunity to affect the retina in such a major way. Now, coming to the non-infective causes of posterior uveitis, I am not going to detail of these individual diseases because they are collectively known as white dot syndromes, and just to enumerate them with a representative picture which I have collected from internet. So this is acute posterior multifocal placoid pigment epitheliopathy, or commonly known as APMPPE, and it occurs in young individuals 20 to 40 years of age. It is rare in children and it has an equal predisposition to occur in males as well as females, and it may be bilateral but asymmetrical. So there is asymmetry that one of the eye is more affected than the other one, and the duration ranges from weeks to months. Recurrence is rare and there is minimal of vitritis. We can appreciate here, this is a color fundus photograph showing these small dots of inflammation in the choroid, and when looked through a angiography, fundus fluorescein angiography, we can see in the early phase there is dark spots corresponding to the area of inflammation, indicating the masking of the fluorescence coming from the choroid because of the opaque overlying tissue which is choroid and retina. And then in late phase it changes to a situation where these dots become hyperfluorescent because of the leakage and staining of the tissue. This is one OCT which is showing us the cystoid macular edema which has occurred secondary to the inflammation of the choroid and retina. Second disease in this list is multiple evanescent white dot syndrome, also known as MEWDS. Now this occurs in young individuals, especially in myopes. It is more common in females and it is unilateral, and the duration is from weeks to months. Recurrence is rare and there are small, round, slightly indistinct white, yellow, white spots distributed along the posterior pole, especially around the fovea in this area, and they are at the level of retinal pigment epithelium. It heals rarely by scarring, so the visual prognosis is usually good, and we can see The layer involved in these further photographs, this is one OCT which shows that rest of the retinal layers are fine, and when it heals in active state, the retinal pigment epithelium, which is represented by this bright line, is irregular, and it includes the further photoreceptors also which are disturbed, and when it heals, this line smoothens out because there is hardly any scarring in this disease, and that is why the vision usually is regained well. On angiography, we can see that these spots appear as dark spots or hypofluorescent because of the blocked fluorescence by the inflamed retinal pigment epithelium and choroid. And this is OCT angiography autofluorescence image, which shows us the presence of these spots which fluoresce in presence of due to the disease process. And autofluorescence means that there is no dye here, it is just the light which is being projected onto the fundus, and those structures which cause fluorescence are highlighted. Another disease which is commonly known as serpiginous choroiditis or geographic helicoid peripapillary choroidopathy. The age of onset is 30 to 60 years. It is more common in males. It is usually bilateral, although it is asymmetrical, as you can see in this photograph. This is a patient who has suffered from this serpiginous choroiditis in past, and this is the area which is affected in the left eye, and this is the right eye where we can see inflamed ongoing inflammation, and these are the areas where the scarring has occurred, especially the pigmented areas. Same goes here. This is all old scar which has occurred because of the serpiginous choroiditis. It's a chronic and recurrent disease which gradually affects newer areas of the fundus and may result into a gross loss of vision. On angiography, we can see that there is an area of blocked fluorescence because of the inflamed tissue, and then you have staining and hyperfluorescence of the scar areas, the border of the scar areas. So this basically represents the picture in a fundus fluorescent angiography when the disease is active in this area and it is healed and scarred in this area. Multifocal choroiditis, as we had seen that this can be a clinical picture, but multifocal choroiditis itself is a particular entity. It is more common in myopes, more common in females than compared to males. It is recurrent, and you have moderate anterior uveitis associated with this situation. And this patient, we can see punched out lesion which are formed because of the past episode of multifocal choroiditis. Another disease, birdshot choroidopathy, where we can see these round areas of choroiditis which are discrete. They are covering the posterior pole, posterior to the equator. They are at the level of retinal pigment epithelium and inner choroid, and they are usually concentrated at the posterior pole, as you can see in this photograph. It is more common in females when compared to males. It has mild hyperfluorescence and late staining in late phase, and angiography shows window defects, so which cause hyperfluorescence of the underlying choroid fluorescence. Subretinal fibrosis and uveitis syndrome is a disease where, along with the choroiditis, when you have the healing occurring, there is fibrosis of the underlying subretinal tissue. So this causes a lot of damage to the whole of the layers of the retina and results into a poor vision. This is a recurrent disease, so it can recur and cause extensive damage to retina. Then there is one disease, sarcoidosis, which is a multi-system disease. It can affect lungs also, and in the eye it can affect the anterior segment also, so it can cause a panuveitis. And when usually affecting the posterior segment, it can affect the optic disc. Here you can see the optic disc is swollen. It can cause vasculitis, so we can see the blood vessels. There's an old area of choroid scar, and it can cause significant exudative choroiditis, which can cause exudative detachment. Then there are few more kind of posterior choroiditis. Is a distinct entity, but they are more or less common in Indian subcontinent, so I am not going to discuss with that. Now, looking at all that classification and types of choroiditis a person can or a patient can have, what are the presentation of choroiditis? So coming to the symptoms and sign. So when you have involvement of the posterior pole or the inflammation in the vitreous, the vision drops down. Then there is another symptom which is very specific to choroiditis, that is photopsia. That is a subjective sensation of flashes of light resulting due to irritation of photoreceptors. The opacity in the vitreous, which can cast a shadow on the retina and which can move slightly, they form the floaters. So these are basically shadow of the opaque opacities floating in the vitreous, and when the eye of patient moves, these shadow move, so they are something like a floating opacity in the visual field. Now we can have metamorphopsia. This is because of the retinal edema, so the image which is formed on the retina is distorted, and this can cause micropsia, that is the objects which are seen are appearing smaller than they are. This is when you have separation of visual cells which can occur at the apex of a edematous area, and you can have macropsia, where the things which are seen are little larger, which can occur at the periphery of the edematous area. Positive scotoma, that is a defect in the visual field which is large, and patient can perceive that as a dark area in the visual field. So these are the possible symptoms of a patient suffering with choroiditis. Then there are signs. So in active stage versus healed stage. So when the disease is active, there may be vitreous opacity, which can be fine, coarse, or large due to exudation. Choroiditis lesion, as we have seen in previous pictures, they are all looking pale yellow or dirty white raised area, cream colored area with ill-defined edges, but they are distinctly discolored from the surrounding retina. And the retina, which once it is involved, is often cloudy and edematous, as we have seen in retinitis patients, the viral retinitis. When this lesion heals, the affected area becomes more sharply defined and delineated from the rest of the normal area. The involved area shows white sclera below the atrophic choroid and black pigmented clump at the periphery of the lesion. So central area is relatively white because of visibility of the sclera, and the periphery, where there is hypertrophy of the pigment, it becomes dark and black in color. Diagnosis of the choroiditis. So usually the clinical picture, including the fundus evaluation, is sufficient to diagnose the choroiditis, but there are ancillary tests which are used to diagnose the related complication and pinpoint the cause. So fundus photography is one of the very good method of documenting the amount of damage which has occurred and the area involved. Then we can have a fundus fluorescein angiography, and here we can see a patient with serpiginous choroiditis, where this area where you have the active disease is showing an initial hyperfluorescence because of the opaque and edematous choroid in retina. Later on, as the time passes on, the same area they become hyperfluorescent, and later on they stain, so they are hyperfluorescent when compared to the rest of the retina. So fundus fluorescein angiography for most of the types of choroiditis is slightly different, and this can be used to clinch the specific diagnosis. Now there is one more angiography, which is indocyanine green angiography. It has a distinct role in identifying the leakage in the blood vessels of the choroid, because the fluorescein dye that is seen by blue light and it appears green in color. So when we have an intact retinal pigment epithelium, any dye which is circulating in the choroidal blood vessel cannot be seen because of the opaque retinal pigment epithelium. But this is not so with the indocyanine green. Indocyanine green is seen through using an infrared imaging technique, and the color or the infrared imaging can see through the retinal pigment epithelium. So in this image we can see the choroidal blood vessels, which we can appreciate that this area is slightly hazy. This indicates the leakage from the choroidal blood vessels. Now, optical coherence tomography can help in pointing out few associated features. Like in this first image, A and B, we can see the vitreous is having opacity, and when the disease heals, the vitreous which is overlying in this area in the same patient after a while becomes absolutely clear. Then you can have swelling of the choroid, which is seen here in this cross section. These are the retinal layers. This is retinal pigment epithelium, and this is the choroid which is affected by choroiditis, and it is thickened. And when the lesion heals, this thickness reduces. Normally something like 300 micron is acceptable, but anything more than that is considered diseased, although this can also vary among individuals. When we look at the optic nerve head, which can again be the thickness of the retina in this area can be measured using optical coherence tomography. We can see during the disease, when the optic nerve is inflamed, the choroid is thickened, the retina is thickened, and once this lesion heals, you can see this area which is corresponding to the choroid is swollen here, and then the healing occurs, it becomes of normal thickness on both sides of the optic nerve. So these are the utility of optical coherence tomography in our patients. These are few complications of choroiditis which can be again seen well with the optical coherence tomography. Here we have a patient with cystoid macular edema. So a foveal area which is usually having a dip in this area is edematous, and we can see cystoid spaces in the tissue. You can have epiretinal membrane once the scarring and healing occurs. Here we can see similar situation. There is a overlying reflective membrane on the retinal surface which has caused inversion of this foveal dip, and these white areas indicating the presence of this white epiretinal membrane. One can have a choroidal neovascular membrane. We can see this extra deposit of tissue here in this area, and absence of thinning or of the retinal pigment epithelium. This is subretinal neovascular membrane, which is a fibrovascular growth occurring from the choroid into this subretinal space. And this is seen very well on a OCT angiography, where we can see this angiography of or presence of lacy blood vessels, which indicate this area of choroidal neovascularization. Now this ultrasound can help in situations where the media are opaque and we want to look at the thickness of the choroid, plus in presence of severe inflammation of choroid sclera, the surrounding tenon space can have fluid collection, and this results into a T sign. So you can see there's a T sign forming here. This is the optic nerve head, which appears as a void or hyporeflective area on our B scan, and this area, which is the edema in the subtenon space, is because of presence of fluid here, and these two shadows or hyporeflective areas in combination give up appearance of a T. Now coming to the treatment of choroiditis. So non-specific therapy for all the choroiditis is to restrict the amount of inflammation which is occurring at that site, because this inflammation is going to cause damage to vital layers of retina, and resulting damage will cause a scar formation where the tissue is destroyed and replaced by a fibrovascular tissue which is not functioning. So steroids are given in oral, intravenous, subtenon and intravitreal formulations. Intravenous methylprednisolone is given when the threat to the vision is imminent and urgent attention is required to limit the amount of damage. Subtenon and intravitreal are given in a situation where a long-term maintenance has to be given, and the health caregiver, the doctor, wants to avoid the systemic side effect of systemic steroids. Rarely, immunosuppressive agents may be required to check the inflammation when patient has to kept on steroid for a very long time, which can cause Cushing syndrome, which can cause other diseases as well. Now coming to specific treatment, when it comes to the infective causes like toxoplasmosis, toxocariasis and tuberculosis, there are specific treatments needed to be given to these patients so that the pathogen can be taken care of, apart from the anti-inflammatory agents which are mentioned here.